Okay, good morning. Let's start. Today we are going to present a webinar on understanding the mechanical environment of the hip joint. Our presenter today is Jan van Houcke. He's a hip surgeon at OLV Hospital, Aalst in Belgium. Jan, from the early days, was interested in science and mathematics, and during his medicine studies, he completed his thesis on hip kinematics in the patients with femoral acetabular impingement. And after this, he continued his research under supervision of Professor Emmanuel Audenaert from Ghent University. And his PhD was about the understanding the mechanical environment of the hip joint. So today he is going to present this topic. So for the presentation today, we are going to give you a brief introduction to the antibody modeling system, and then Jan will do his presentation, and after this we will have a short Q&A session. Okay, let's introduce the antibody modeling system. Antibody modeling system is a software that allows you to do musculoskeletal simulations. Typically, as an input, you get some motion data. You can input kinematics, so the motion of the human, and external forces, for example, the force plates or the forces acting on the human. And after this, you construct a model in the antibody modeling system. As an output, you get information about the internal loads and muscle activations. And this is how the system looks like. So the system is used in different fields. For example, in movement analysis, gait analysis. It can be used for optimizing your products to make them more ergonomic and human-friendly and safer. You can also use the system to improve sports performance by understanding biomechanics of your athletes. It can also be used in medical fields, so to understand behavior of the medical devices and for rehabilitation analysis. And the very hot trend right now is to understand assistive devices, exoskeletons, using simulations. So once again, the antibody modeling system works as follows. So we have our human body model, which we subject to motions and external forces. We add the environment, and once everything is constructed, we do the simulation. And the simulation is inverse dynamics analysis, meaning we go from motion to internal forces, and we need to make an optimization of the muscle recruitment. And this is what the system does. So it replicates the central nervous system behavior to activate all the muscles to produce necessary motion. And once this is done, you get a simulation like that, where you can look at all the internal loads in the body, and also interaction with the environment if needed. And this can all be after that sent to a post-processing environment, for example, a finite element package. And this can, of course, all be then looped into design optimization loop. So now I'm going to give the word to Jan to do his presentation.
So good morning. Thank you, Pavel, for the nice introduction, as well as for the introduction on the antibody modeling system. I'm happy to present a big part of my PhD thesis, which I recently defended, and I hope you can all enjoy it. So I'm part of the orthopedic research department in Ghent, currently working in Aalst. For the people who don't know Ghent, it's a vibrant city in Belgium, Europe. Anybody who has the time or is interested, come and check it out. It's definitely worth a visit. Jumping right into it then, into the presentation. Here we have some images of what we call hip osteoarthritis. This is the end stage of the disease in the images that you can see. If we know that most of people, or at least an important part of the people in the Western world, about 25%, will have to deal with hip osteoarthritis by the end of their lifespan, then we can definitely state that this condition is a major health concern. But is it really that big of a problem? Because for the people who are into medicine or orthopedics, they know we have a good solution for dealing with it. The pain becomes too much, we can simply replace it with a brand new spanking hip. It's the total hip arthroplasty. It has a high patient satisfaction, a lot of people with a forgotten hip score, etc. So the results of the surgery for the right indication are good, even that good that we managed to get a publication in The Lancet, one of the leading journals in medical literature. So if your grandma gets hip osteoarthritis, you simply do the surgery, put in a THA, and after a few months of rehab, she will be able to get back to her daily life activities. But it's not always that easy. What do you do with young adults with clear hip pain, total hip arthroplasty? We know that it's meant to last around 25 years in ideal circumstances, but after that, you get loosening, you get stress shielding, you get fractures. And this is not to be underestimated. What about dislocations, which can happen early on? So THA surgery is definitely not always the first choice, especially not in young adults. Hip osteoarthritis used to be something that was a little bit of an enigma. The real causes for hip osteoarthritis, such as clear dysplasia, trauma, childhood diseases, inflammatory disease, are only 50% of all the cases of hip osteoarthritis. So it used to be a lot of primary cases, but we know now with the past 20-30 years that most of these primary cases are actually attributed to femoral acetabular impingement. And this is a mechanical hip disorder, which can be defined by the fact that it has an early and repetitive contact between the acetabular rim and the proximal femur, which ultimately gives rise to hip joint cartilage and labral lesions. And it's mainly a problem in young adults. In the later stages of life, it's simply called hip osteoarthritis. Shape variation, such as the cam or the bump that we see, or the over coverage in the pincer case, makes it hard to distinguish between normal variation, a little bit more coverage, a little bit more asphericity at the proximal femur, and then of course the healthy cases. So we know that typically in nature we have a normal distribution of these things. If we specifically talk about a cam, at which point does the proximal femur get pathological, and at which point is it still something physiological, just an anatomical variation without any consequence? How big does it have to be? How far away does it have to be from the average? So how many standard deviations from the mean? That's something that's really fascinating that we want to find out. But maybe it's not only that cam or that bump. It's on the proximal femur. Maybe we have to focus also on the other side, the acetabulum, the overall coverage, and the combination with that proximal femur and that possible cam. What if we look a little bit further and we evaluate the neck shaft angle as well, look into the femoral version and its effects on the torque or the moment that can be generated and the consequential reaction force in the joint. So what if we move away from static images and make that subject, make that anatomy move and see what reaction forces result from it and what the combination of the extra-articular anatomy produces. But in the end, our final or our most fundamental question is what contact stresses are happening inside of the hip joint during these motions, and do we get pathological joint stresses? And more importantly, if these are elevated, are we able to actually normalize them or improve them with surgery are we able to get back to a healthy hip or a normal hip situation. So that is what brings us to the aims of this work. We wanted to develop a pipeline ultimately for exploring the impact of shape variation and the surgery to improve on it by actually looking at the contact stresses of the hip joint. And to be able to do that, we had to run through some steps. We first had to explore hip joint reaction forces in static and dynamic environments. We did it. We had to look into the hip joint contact stress patterns and figuring out ways to actually calculate these contact stresses. And then we explored the impact of these two previous findings on cam resection surgery, and looked into whether or not we were able to do something with that surgery. So in order to understand the loading of the hip joint, we wanted to focus on some static and dynamic activities. We applied a computational modeling design with the antibody musculoskeletal system, which, as has been mentioned, uses an inverse dynamics approach and takes all the external forces, motions data, and then after some optimization allows us to calculate the internal forces, which is mainly the joint reaction force that we're interested in. For the static motions that we looked into, it was the sitting configuration that we wanted to find out, because we know that in hip joint pain, in FAI patients, we know that prolonged sitting, deep sitting, can trigger these complaints. Prominent bumps or big bumps have been shown to result in an early conflict, even around 60 degrees of hip flexion in some cases. And we are a society that is mainly sedentary, so we sit a lot during the day. And for that specific reason, we looked into 3 common sitting configurations: the car seat, simple chair, and the kneeling chair. As mentioned, we used the antibody system to look into that. We used the average adult Caucasian male, which is available in the antibody system. We built on the validated seated application model from the AMMR from a previous work by Rasmussen et al. And we checked the results that we were getting by also performing a validation with orthoload data from 3 male subjects, in which the sitting configuration in a regular simple chair and a car seat was available. We found by calculating the joint reaction forces that these were quite similar in the simple chair and car seat configuration, whereas in the kneeling chair configuration, we had a reduction of these joint reaction forces about 50%. Hip flexion, due to the nature of the configuration that we had the model sitting in, was also quite lower in the kneeling chair configuration compared to the 2 others. So in that way, in that perspective, we were able to indicate or point in the direction of the kneeling chair as also a potential ergonomic sitting tool compared to the regular simple chair and the car seat. Next, we looked into some more interesting cases, which are the dynamic activities, and especially the ones that can be a bit more challenging for the hip joint as well as for other joints, of course. The deep squat is available for doing further kinetical and biomechanical evaluation with, and that's thanks to Bergman, which has constructed the Julius Wolf Institute in Berlin, has made a lot of data available on, for example, also some knee bending activities, which are useful, of course, but this library has been built with mainly older subjects which were in need of a total hip replacement. and that got an instrumented implant. So that allows us to give us some in vivo detail on joint reaction forces and also kinematics. But a 50-degree hip flexion and 90-degree knee flexion, which is about the knee bending that you'll get in these older individuals, cannot be compared to the knee bending or deep squatting abilities of young subjects, which we are interested in. So since these kinematics and kinetics should be clearly different, we wanted to look into this by using musculoskeletal modeling approach. So a second reason for looking into that is the data that are available of the OrthoLoad, the database, are of a few subjects, but what if we want to look into the specific loading of the joint of one subject? What if we want to work towards personalization and personalized anatomical information and the subsequent biomechanical information? We know that varus valgus, pelvic width will all have an effect or can have an effect on the required muscle forces, and as such also the resulting joint reaction forces. So we wanted to first report functional range of motion in young athletic adults, as well as their hip joint loading during these challenging motions. Secondly, we wanted to build on a personalized modeling solution for estimating these reactions during the deep squat. For that specific reason, we actually gathered a fair group of athletics males. These were recruited if they were aged 18 to 25 years old, and we trained them to perform systematic maximal depth squat in a gait lab setup that we built ourselves. We put reflective markers on each segment that was mobile, and after we did the gait lab analysis, we replaced the reflective markers by hyper intense vitamin A beats, because the next step was to put all these subjects onto an MRI scanner to get their personal bony morphology, as well as get the positions of these reflective markers, which are represented by the vitamin A beats. And in that way have a much nicer workflow to actually calculate the further muscle and joint reaction forces. A segmentation of all the relevant bones was done using a mimics and dedicated own MATLAB segmentation. So once again, it was done using the antibody modeling system. We included the latest Twente lower extremity model 2.0 muscle definitions. This update also included an improvement in the muscle trajectory for the gluteal wrapping, which was an important factor for allowing us to calculate realistic joint reaction forces. The second important new step was to include a personalization flow in which the bony geometry between the antibody template bone and the subject-specific bone was adopted using a non-rigid registration algorithm. And by using that transformation in a non-linear way, we were able to scale the musculoskeletal geometry from the antibody template all the way to the, the subject-specific or the subject itself. The right shank, right thigh, right pelvis were used for this purpose, and the left side was scaled because we were assuming to have a symmetric body shape, of course, since these were young adults, and there were no cases of fractures or something else like that. The inverse dynamics protocol with a polynomial muscle recruitment solver was used, and we also had the skin marker position, as mentioned in the previous slide, directly from the MRI. which allowed us to also cut down on the optimization algorithms required to find the position of the markers relative to the bones. So that's there we go. Data were then normalized, first for direction forces in terms of body weight. Then the deepest point of the squat was defined as the peak knee flexion. That was then the 50% point of our motion. We used a quadratic interpolation to establish that. And then also the squatting time was aimed to be around 4 seconds, but even though with training and stuff like that, there's also always some slight inter-individual variation. And in order to normalize that, we used the partial least square regression method to obtain that. Then validation was performed using the available data from the Ortholode library, knee bend trials from 3 subjects, and we specifically constructed our model to perform the same motions as the knee bend trials did, and then compared our outcome with the in vivo measured hip joint reaction forces. We found that the agreement was good to fair. During squat progression, the peak hip joint reaction force was on average some 10 to 40% lower with the antibody model compared to the in vivo measured values. Reaction forces of the joint amounted to 247% body weight at a peak hip flexion of 107 degrees. The direction of the hip joint reaction force was typically in a posterior medial direction in relation to the acetabulum. So we can conclude that the hip joint kinematics do differ in these young healthy adults. We were able to establish some reference values for healthy young subjects in that way. And also we managed to build a personalized kinetical evaluation pipeline to look into extra-articular variation. And this can, of course, be an important step towards population-wide modeling. Second, we looked into building a toolbox for studying contact stresses in the hip joint. As we know, it's possible to do that in cadaveric experiments in vitro by placing a pressure-sensitive film in between the femoral head and the acetabular and putting a certain joint reaction force onto the system and looking into the contact stress patterns on that pressure film. However, it's not feasible in real life, of course. The golden standard to get your contact stresses in the hip joint is currently the finite element analysis technique, which is very decent and accurate, but of course it's CPU intensive and also time consuming to build these models. Cartilage geometry is also a difficult item. We know that there's lots of literature on the fact that the manual segmented, highly detailed cartilage geometries outperform parametric solutions, but it's extremely labor intensive to segment this on a hip joint. In that way, we wanted to actually develop and validate a more straightforward tool for the evaluation of hip joint stresses. We did this by, first of all, developing another way to predict your cartilage anatomy. We used the population average technique, in which the cartilage thickness is not constant or is not spherical, but is actually defined per node on the acetabular and the femoral head surface. Along each node, each position on the anatomy, we extrude along the surface normal by then a fixed height or thickness. We based our values we based the values of this anatomy thickness, which had local differences on the anatomy of 10 subjects, which were manually segmented, and we compared this average population averaged cartilage anatomy to other parameterized alternatives, which are the constant thickness methods, in which you just put the 1 millimeter or 1.5 millimeter layer on top of the bony geometry, to also the spherical fit, in which you fit a cylinder, a sphere, and then fill it up with cartilage to get your contact surfaces. And then secondly, of course, we implemented a discrete element analysis technique as an alternative to the FEA. This was a 2-layer spring model in which we also only looked into the compressive forces. We evaluated nonlinear and linear cartilage properties, and then of course we did a verification and validation of this. Our validation study group was based on a study from Harris et al. From the University of Utah, in which they looked into 10 healthy adults. They did an arthro-CT and reconstructed the hip joint morphology, as well as they did the manual segmentation of the cartilage. They put these joints through 3 loading scenarios: heel strike, during walking, ascending and descending. And they finally evaluated the contact stresses using an FEA, a validated FEA routine. And we compared their golden standard FEA results with our more straightforward way of using the DEA in combination with population averaged predicted cartilage geometry. The cartilage definitions and the geometry itself of this population averaged method showed good agreement with a root mean squared error of 0.3 millimeter. And it didn't have the same consistent deviations from the anatomy of the subject as the spherical fit and the constant thickness method had. In both spherical and constant thickness fitting, you typically have an underestimation of the cartilage thickness in the superolateral acetabulum and the anteromedial femoral head, compared to the population average, where you had that smoothened out effect because of the local differences in the cartilage thickness. So when we combined the DEA protocol with the population average cartilage and we compared that to the manual FEA, we saw consistently that the peak stresses on the cartilage were consistently elevated by 1.68 megapascals. The contact area was consistently lower, about 20%. And these are values or data that we also typically have or see in other DEA implementations, but they are consistent. And for that specific reason, in combination with the fact that the analysis only takes approximately 1 minute compared to sometimes in 1 hour in some FEA routines, can be seen as valuable, I guess. The DEA with the population averaged cartilage prediction method as such offers a suitable alternative compared to the more laborious FEA modeling systems. We had a consistent underestimation of contact area as well as an overestimation of the peak hip joint reaction forces, but nevertheless contact stress patterns were quite similar, and these over and underestimations are consistent. It offers an important computational advantage, and as such we used it for some further steps. We wanted to look into the effects of CAM FEI surgery, because we know that the resection of the proximal femoral bump, or the CAM, is something that is already being performed in open or arthroscopic surgery. The aim of that surgery is to get rid of the mechanical conflict as well as prevent hip osteoarthritis, or at least delay it. Currently, the collision range of motion collision detection is the method that's mostly and widely used, but it doesn't give us any information or cartilage on joint cartilage stresses, as well as on the fact that the surgery is able to normalize these joint stresses or not. So We looked into the contact mechanical impact of this resection in CAM FAI patients, and therefore we assembled a group of 10 patients with an alpha angle of more than 55 degrees. We put them in an impingement test loading scenario, and we looked into the contact stresses using discrete element models with cartilage prediction as validated in the previous study. And we developed or assembled 3 groups. We had the preoperative CAM patients, then we had the 10 same patients in their postoperative CAM resection geometry. And then in the third phase, we also gathered a matched virtual control, which was in fact the same proximal femoral geometry of our patients, but with the exclusion of the CAM site, so the head neck region from 11 o'clock to 3 o'clock. And then we fitted, using a statistical shape model built of young healthy adults without any CAMs, we fitted the anatomy so that we could have a sort of healthy twin with that same proximal femoral anatomy, except for the head neck junction, which was filled in to be the healthy twin. By doing so, we saw that in our demographics, that the CAM was had an alpha angle of up to 73 degrees in the preoperative setting. Postoperatively, in all 4 o'clock positions, we saw that the CAM was, or the alpha angle was below 50 degrees. In the healthy twin situation, these values were just a tad lower compared to the post-op situation. The contact stresses during varying degrees of internal rotations and 90 degrees of flexion of the hip amounted in the preoperative situation all the way up to 60 megapascals, compared to postoperatively, where we clearly saw that these contact stresses in terms of megapascal were decreased. This was also the case in the healthy twin situation, and we saw that from 15 degrees of internal rotations that the differences in the decrease of peak contact stress was significant at the 0.01 level. So we can conclude that a complete and accurate resection of the CAM deformity at the proximal femoral neck can restore the contact mechanics of the cartilage in the hip joint with CAM FAI. This cannot be extrapolated in the presence of articular cartilage damage, and long-term outcomes are not available with this technique. But we do know that if the cartilage damage is not yet present, that the contact mechanical situation can be restored with an intact cartilage. So on the figure on the right side, we see the typical pattern of the anterolateral conflict with the posterior inferior elevated peak contact stresses in the at the contra-coup part of the acetabulum during increasing amounts of internal rotation. And this is normalized in the post-op situation as well as in the healthy twin, which is in fact the most healthy proximal femur anatomy that you can get in this kind of subjects. So in the future, or at least the current days actually, we have also looked into some other daily activity lives. Our study group of young adults were not only subjected to its deep squatting motion, but also a lunge motion, which is in fact once again a deep flexion, highly loading situation. And we used that same routine with our gait lab with personalized musculoskeletal geometry to also get more kinetical data on this matter. We found that peak hip joint stresses amounted to even higher values of up to 5 or 6 times body weight during a deep deploy lunge. The lunge as well as the deep squat data were then taken into a different routine to actually try to improve on our steps towards population-wide techniques. We took the data, the kinematical data, which are hip flexion, knee flexion, ankle flexion, also the time of squatting and so on, which are nonlinear data. We normalized these using standard deviation, mean-centered the data, and then put this through a principal component analysis based on the residuals, which allows us to build a model and look into these kinetical data in a different way as before. For example, for the lunge, this was done. The building of a statistical model allows us to find out which variation, clustered variation in the motion of our subjects is available. The first mode in the lunge specifically showed us that it was mainly the depth of the lunging gesture itself that described most of the variation in our kinetical model, in our statistical kinetical model. The second mode, for example, then was the fact that the internal rotation and adduction during lunge was different in between our 50 subjects. And then the third mode showed us that the ankle dorsiflexion and the amount of dorsiflexion during that high flexion motion in the hip joint was also different. And each of these modes have a decreasing amount of variation within the models that they describe. So the first modes are the ones that represent most variation within our study group of people that did the lunge gesture. We built a statistical model of the lunge. We also did it of the squat. We are also looking into the kinetics of some other motions, taking steps and ascending stairs, descending stairs. At this particular point, I know that there's one student working on the cycling activities. We had 3 different cycling heights, going from very deep and low seated cycling, which you have in a racing bike situation, for example, all the way up to more trekking or mountain bike position, which you're sitting more upright. In that way, we could also look at the kinematics, of course, without any feedback from the force plates. So we didn't have any joint ground traction force data, but that is what it is. Then we're not only looking into musculoskeletal modeling from anybody and so on in our research department. We have also been working on automatic segmentation, which is the main topic or one of the important advances that Professor Emmanuel Audenaert has done. And this allows us to go quicker through CT scans and get the personalized anatomy of our subjects in a faster and more representative way. We also are including muscles in our models. One of these that we've done is the psoas wrapping to look into impinging and snapping psoas situations. The statistical kinematical models are the ones that I've just shown and what we're also working on currently. Gender specific differences, men versus women, in terms of anatomy, in terms of kinetics, are also on the agenda. We have been working on some anatomical details as well. And then finally, or most importantly, all of these data are to be assembled into population-wide models, which means starting from different subsets of 50 to 200 subjects, some of which will have performed kinematical evaluations, some of which will have highly detailed anatomy. Combining these to actually get the kinematics from shape, or get from shape kinematics, get contact stress evaluations, and so on. In that way, we're able to draw some conclusions, and more importantly, also sometimes generate study groups, virtual study groups, by using multicardial sampling, and so on. We have introduced the cartilage layers in our models at the hip joint. Currently, we're also working on this in the ankle joint, where we also include the cartilage geometries. And as a next step, we're introducing the ligaments, such as the tip-rib syndesmotic ligaments, the lateral ankle ligaments, as these are important in developing our DEA models, since they are the ones that also will result in some constraint and will have an influence on ankle joint reaction forces. This development of the cartilage, as mentioned in the hip joint, is also being implemented on the ankle joint, in which we have our cartilage thickness, which is locally different based on anatomical segmentations. And this is included in our statistical model of the talus and the tibia that can be fitted along with the geometry of the bone. Then the cartilage can be, I should say it, extrapolated. In that way, we're hoping and working towards the idea of going from force-dependent kinematics to some sort of shape-dependent kinematics, and actually trying to simplify the routine or the way to go from a certain anatomy all the way to certain joint stress pattern and loading. One more figure on the way that we're actually implementing these cartilage thicknesses. In the ankle joint as well, we saw that using a constant thickness layer would also result in a severe underestimation at the center of the talus and overestimation at the edges, compared to a more vertex-specific population average thickness layer, which actually fits the subject much better. We're also looking at the knee joint, but this is a little bit more in early stage than the ankle joint is. Once again, combination of cartilage as well as the ligaments around the knee in order to optimize our DEA results and get a more physiological understanding of the stresses inside of the joint. So once again, back to the hip joint, we know that we want to identify our hip joints that are at risk for hip osteoarthritis. We want to evaluate the effect on contact stresses with when we're doing surgical femoroplasties, arthroscopically or open, or reorientational osteotomies of the pelvis or the proximal femur, and these techniques that I've just mentioned are the ones that enable us to do so. We are further looking into the daily life activity kinetics of not only deep squatting but also lunge, stairs, cycling, and so on. And finally, we are slow but steadily working our way towards statistical population-wide models, enabling us to study more detail and also enable us to have a quick toolbox to go from hopefully shape all the way up to contact stresses in different joints of the body, lower limb so far. Thank you very much for your attention. I'm going to switch over to Pavel, I guess, now.
Yes, thank you, Jan, very much for a very interesting presentation. Okay. Thank you very much for your presentation once again. I'm going to say a few words now about the upcoming webcasts and so on. And after this, we will have a Q&A session. So I invite you to submit your questions now while I'm talking, and then we'll go through the list of questions. Okay, so first of all, I would like to invite you to visit our website, where we have the list of events, the dates of the upcoming events, publication list, and so on. You can also visit our wiki page on anyscript.org. We also have access to all the repositories, the current repository and the previous repository, and there is also a forum where people ask questions and we answer them on a daily basis. And I would also like to invite you to our next webcast, which is going to happen on 1st of December. It is going to be a talk about the new musculoskeletal any-body detailed hand model. It will be presented by people from Germany, and it is going to be very interesting. So, and if you would like to ask us about something, technical questions or sales question, please send an email to sales@anybodytech.com. And if you want to present, please send an email to my colleague, Christopher Iverson, to ki@anybodytech.com.